My name is Sigal Yavitz. I'm a member of the infectious disease faculty at Brigham and Women's Hospital, and I'll be speaking today on urinary tract infections for internal medicine. There's a bio attached, and you can learn a little bit about me. And I have no commercial conflicts at that time, just for your information, not because it's required. I included some activities I do outside of the Brigham that are associated with UTIs. So what we're going to cover today are inpatient and outpatient issues in UTI that are relevant and are challenging to internal medicine providers. There are a lot of updates this year, so this doc updates previous talks I've given, and there is a lot of information that's quite new. We're going to start with talking about simple cystitis and diagnostics in UTI. We'll talk about UTI syndromatic definitions, which have changed a little bit over time and now officially changed in the national guidelines. When to test and what tests to order when you diagnose different syndromes of UTI, and how to select empiric and definitive treatment. And we'll start with simple cystitis and then move to more challenges in UTI management. And the challenges include treating multi-drug resistant organisms, whether it's simple or complicated UTIs, treating cystitis and prostatitis in men, again, simple cystitis or complicated UTI, managing complicated and bacteremic UTI syndromes, which is a very diverse group of infections, approaches to asymptomatic bacteriuria and a catheter-associated UTI, and evidence-based strategies in management of recurrent UTI. And that should cover pretty much everything that you will need for practice and also for board exams. So I'm going to start with a case presentation. Just board questions are often case-based. So we're going to start with a simple cystitis case. So this is a 47-year-old woman. She has a high BMI. She has prediabetes. She's not pregnant and has no other significant medical history. She's on no medications. And she calls to report a 3-day history of dysuria, urinary urgency. She had prior similar episodes about once per year, so she knows it's a cystitis or UTI. She has no fever, nausea, vomiting, flank pain, or any red flag symptoms. And she was not recently in the hospitals or on antibiotics, except she had malaria prophylaxis for a trip with Malarone. So by definition, and we'll get through the syndromes, this is simple cystitis and previously was known as uncomplicated UTI. I made her younger than 50, so she meets both definitions, and we'll talk about that in a bit. And that's because she has classic lower tract symptoms, dysuria, urgency, and frequency, suggesting of cystitis, but no upper tract symptoms, so no pyelonephritis or fever. So syndromatic definitions have changed. We have just published the complicated UTI guidelines late in 2025. And the old definition defined uncomplicated UTI as acute cystitis in a young woman without any other metabolic or urologic abnormalities. And it included acute pyelonephritis in that group. And the new classification tries to make it simpler in many ways. So uncomplicated UTI is what's really uncomplicated. It's a simple cystitis, but the population can be more diverse. It can include women or men, and it can include diabetics or postmenopausal women if the syndrome is simple cystitis. And then complicated UTI is everything else that's not simple. So it's pyelonephritis, febrile or bacteremic UTI, catheter-associated prostatitis, etc. So the complicated UTI guidelines cover those that are new. So I included here in a clearer version, just for your reference, the same in a more legible slide, but it includes the information from the last slide that's taken from the guidelines. So this is a woman who's 47, who has simple cystitis. So she has uncomplicated UTI by all the new guidelines. And the reason why I included that is the uncomplicated UTIs are in the process of guidelines are in the process of being updated, but are not yet. And the old guidelines use the old definition. So there is a little bit of a mismatch currently between the uncomplicated UTI guideline syndromes and the complicated UTI syndromes. So the questions we ask ourselves when this woman calls us is, do we order tests or we just prescribe something on the phone call? Does she come in to be tested or do we just treat her empirically? And for those, and when I talk to people in person, not in a recorded way, when I ask people what do they do, it's about half and half. And then when obtaining tests, what tests do I order and how do I interpret them? And if I'm treating, whether empirically or based on tests, do I give immediate treatment or can I wait for the test results? Is it safe? And then obviously how to choose therapy. What's the most appropriate thing to give these days? So I'm going to go through this. So if you don't treat a young person with UTI with a simple cystitis, it's interesting because we actually know what happened, and the reason we know is we used to have placebo-controlled trials for untreated simple cystitis. So we have the arm of people who were not treated. That would not be acceptable today. So I'm including here on this graph is an old study that compared nitrofurantoin to placebo, but it can be any drug. And what we know from this and other studies is that in 2 to 4 weeks, the episodes resolve by themselves in many patients clinically, and ultimately over a long time, the majority of young women, not postmenopausal, who clear their bacteriuria will clear it. And in people without risks, the progression to pyelonephritis, renal failure is rare. So we're not going to harm dramatically people's health. We're going to make them very unhappy if we don't treat them, but not harm them. But this is not true for older people. So that impact of deferring therapy is greater if you're older. So this is a National Health Service in the UK study that looked at adults over 65 who are outpatients. And those who did not get immediate therapy, or whether they got nothing or deferred therapy until the culture results are back, if they had symptomatic cystitis, we're not talking about asymptomatic, that had a higher risk for bloodstream infections and all-cause mortalities. And you can see the diversion here. The no antibiotics did very unwell. The deferred did poorer than those who got immediate empiric antibiotics. So while for young women, it might be safe to wait or give empiric therapy or see if they really have a UTI, for older people, if you think your UTI is better to treat. So what are the pros and cons of testing? So if you test, you know exactly what you got. We know that if they have only one symptom, especially if it's not dysuria, the chance it's UTI is smaller, especially postmenopausal persons. They may have a lot of dryness and other symptoms that may mimic dysuria, frequency, urgency. And negative UA is really good at excluding UTI. I'll show you the data. There's resistance, and we don't want to overuse antibiotics. The cons are that really dysuria, urgency, and frequency, which are acute, are 96% predictive almost of true UTI, cystitis. We can predict, especially in young people, what the organism is going to be. And most people, regardless of what we're going to find, will respond to standard antibiotics. And of course, visits and tests are costly. And there are studies of telephone management that showed that most young people with uncomplicated cystitis will do well with empiric therapy. But what are tests we do for UTI? So the first test we do is not a culture, but we're just looking for, do they have inflammation? And that's defined as greater than 10 white blood cells in midstream urine or 5 in a sediment that we look at. And pyuria is present in almost all cystitis. It's very rare to see cystitis or any UTI without pyuria, unless you don't have white cells, you're neutropenic or obstructed. So the sensitivity is super high. I wrote greater than 90%, but often much greater. However, pyuria without acute cystitis is common as well. There are many reasons to have white cells in the urine, any pelvic infection or inflammation, catheters, etc. So the specificity is low. And the dipstick for leukoesterase is just a dipstick that's trying to find more than 10 white cells. You can also look for evidence of bacteriuria. Are there bacteria in the urine? Remember, it doesn't mean they're causing infection because you don't have white cells. So bacteriuria, the sensitivity is poor because you have colonization, urethral skin contamination. We're looking for low colony counts. The organism, not all organisms find nitrates, produce nitrates. The gram-positives don't, and some gram-negatives don't either. The nitrate producers typically are E. coli and Proteus and Klebs, which are the most common one. And the bladder dwell time, if you have high frequency, you kept clearing the bacteria, and you need about 4 hours to make nitrates. But the specificity is high for bacteriuria. If there's nitrate, bacteria made it. It doesn't mean they cause disease, but they're there to make it. So what are tests that can predict whether you have a UTI or not? So we looked at urinalysis, positive and negative predictive value for UTI. And if you look at that, the positive predictive value is very low for leukoesterase, nitrates, bacteriuria, and white blood cells, because people can have asymptomatic bacteriuria and they can have white cells for other reasons. But the negative predictive value is excellent. You don't see this in medicine where a test has above 90% chance of predicting infection at all age groups, although it goes slightly down in the elderly population. So the bottom line is this: white blood cells, especially in combinations with nitrates, but white blood cells alone, are highly predictive if compared to, say, catheterized urine to see if you really have cystitis. That's why guidelines, especially for stewardship and utilization of labs, which are the more recent guidelines for diagnosis of cystitis, they endorse the concept of urinalysis with reflex to culture algorithms. If you don't have more than 10 whites, you should not do a culture, because it's whether the bacteria are there or not, it's probably not an infection. And the exceptions are those with indications to treat asymptomatic bacteriuria or those you think are obstructed or neutropenic. What about urine cultures for diagnosis? That's important to confirm that you really have bacteriuria. And typically we look for a single pathogen at a certain diagnostic colony count, and we'll CFU stands for colony forming units. And we know the organism, and then ultimately we can get susceptibilities and choose the best antibiotic. So that's the advantage of culture. So the question is, should we really use the greater than 100,000 as the threshold? Most labs don't report less than that. So there is a landmark study by Houghton et al. Published at New England Journal of Medicine, and what it showed, and these are just examples of more than 100,000 in blood agar, in McConkie agar, and then if there are lactose fermenters, they turn it pink, is that showed that if you catheterize people with symptoms of UTI, 70% have bacteriuria on catheterized sample. That's a gold standard for cystitis. But for E. coli, even 30 to 50% of people with true documented cystitis had colony counts that are smaller than 100,000, which means that lower counts are diagnostic of UTI for people with a triad of symptoms. And if you wait a day, they'll just have the higher counts. And for gram-positives, enterococci and group B strep, really no count was predictive, so much more likely to be contaminants at any count. There are people that don't have bacteria and still have symptoms, and then they might have urethritis, unusual organism, or genital infections, STI, or non-infectious causes. People always ask me in recent times about multiplex PCR in UTI diagnosis. Multiplex PCR, like any PCR, looks at DNA and looks at genotypic resistance for the most common resistance mechanisms. It checks for 15 to 30 organisms. It's available in labs, but not FDA approved, so it's a lab-developed study, so we have to remember that. And we have to remember they're not quantitative for real. They're oversensitive. A few bacteria that are dead can still be detected. You don't know if it's colonizer or not. It's because it's so sensitive. And the resistance doesn't always predict the phenotypic resistance. So it doesn't always predict the MIC. So current guidelines recommend against the use. I would say on the side that if you use traditional diagnostics and you have someone with severe UTI or critical, you want to treat right away, it could be helpful as supplementing data in getting the organism and the susceptibility earlier, like we do in blood cultures. So it's not all a no, as long as you use it wisely. The IDSA guidelines for acute uncomplicated cystitis treatment are from 2010 based on the young women definition. And the guideline recommend nitrofurantoin, 100 milligrams twice daily for 5 days, trimethoprim sulfa twice daily times 3 days if E. coli resistance in your area is less than 20%. Geographically, there is no such area in the U.S., but practically there are patient populations that have lower resistance to trimethoprim sulfa. And empiric fosfomycin is an excellent choice, but mostly for E. coli and Enterococcus faecalis. They do not recommend what we consider second line fluoroquinolones or beta-lactams. And the reasons are both because we want to reserve them for other syndromes or for resistant organisms, and because studies in beta-lactams, although there's some newer studies coming out that show maybe equivalence, showed that to be equivalent or to get good response, you need 5 to 7 days, and it depends of which one you use too. Cephalexin and amox are best as far as bioequivalence, and the third generation a little less so. But we know that since these guidelines, resistance may be higher. Efficacy in newer studies is lower than older studies of empiric treatment with those. Remember that nitrofurantoin and fosfomycin are recommended only for simple UTI. So when you have a diagnosis in question or you suspect resistance, I would base treatment on what you think is going to be the organism. Looking at resistance from the National Health surveys of 1.5 million E. coli isolates in U.S. female outpatients, what you can see is that over time resistance are stable, but 25% to trimethoprim sulfa, and there is increase of multi-drug resistance more than one. But look at this guy over here. This is nitrofurantoin, and you can see that nitrofurantoin resistant rates remain low. It's true for our institutions as well, 3.76% of E. coli. And you can see the rates of multi-drug resistance 2 or more. So that brings us to UTI with multi-drug resistant organisms. So this is a patient who is 48. She has MS. She takes ocrelizumab. It's like a rituximab. It's B-cell depleting agents. She has a neurogenic bladder. She has a history of recurrent UTI. And she was admitted for meropenem therapy for MDR E. coli, multi-drug resistant E. coli cystitis. She has symptoms that are classic for cystitis in this population, dysuria, bladder spasm, but she doesn't have systemic toxicity, nausea, flank pain. She has no fever. She has white cells, and she has what the system calls ESBL producing E. coli. So it's sensitive to amoxiclav, piptazo, meropenem, and imipenem. She's admitted for meropenem. And she's admitted for meropenem because she has an amoxicillin allergy. It's resistant to trimethoprim sulfa, fluoroquinolones, and aminoglycosides. So what do you do? So she has a febrile cystitis. In the new guidelines, a simple cystitis, but a multi-drug resistant organism. So she doesn't really need the hospital or an IV, except that's the only thing that works, except amoxiclav, to which she is allergic. So the question is, and I'll tell is, can you use oral fosfomycin? Can you use oral nitrofurantoin? Can you use amoxiclav, or do you have to use an IV carbapenem? And the answer is all of the above. Oral fosfomycin is fine for the syndrome of simple cystitis for E. coli. Nitrofurantoin resistance rates are low. I actually suppressed it, but it was susceptible. And most people with amox allergy can actually take amox safely, we know. And a lot of these allergies, either people grow out of or were never allergies in the first place, especially those from childhood. So in our clinic, we actually either challenge people if we feel it's safe, or do skin testing to allow for amoxicillin use. So when you have a UTI with multi-drug resistant organisms, what is it? So by definition, it's resistant to at least one antibiotic in 3 or more classes, except when you take the health streams, and then it's 1 or more, because this is the definition for hospital infection control, so they can contain people and make sure that precautions are taken to not transfer it between patients. And the risk factors are, you had it in the past, you have recently been in the healthcare system, or you travel to areas or live in areas with high resistance, like Mexico, Israel, certain European countries, etc. And the rates are very high, outpatient and inpatients. So when can you use oral agents? Patient has to be able to take oral agents. They have to have effective oral options for the syndrome. So like nitrofurantoin and fosfomycin, yes for cystitis, no for anything else. And if they're on IV therapy for any reason, like say they have complicated UTIs, you want to make sure they're improved and that you have the right antibiotics. You can do graded challenges or skin tests for remote allergies that limit your options. And if the only oral option is tetracycline, it's a little iffy, because we know doxycycline, a lot of the bugs are sensitive to, but it's cleared hepatically only. It gets in the bladder wall, but it's not excreted in the urine, so you don't get effective high levels in the urine, so the chance of low microbiologic cure is low. So I'm going to do very rapid fire on some drugs, and you'll have the slides for more information. Nitrofurantoin, the dose is 100 twice daily. It has resistant rates remain very low C. diff risk. So the barriers are tissue concentrations are low, so you can only use it for cystitis. And the GFR limitation in the PDR or FDA approval is 60, but it's pretty safe for GFR as low as 30 or elderly population, as long as it's a short course. And that's also in guidelines, in national guidelines, that you can use it at lower than the FDA approved dose. So we use nitrofurantoin also for GFRs that are between 30 and 60. In the elderly, you can have more side effects. You watch for neuropathy and hepatitis, and always keep in mind the very, very rare interstitial pneumonitis. Fosfomycin, it inhibits cell wall synthesis. It's an old drug that was revived. It's now approved in IV as well. And we know that there is reliable susceptibility to enterococcus and some gram-negatives, especially E. coli. And the 3-gram single dose is for simple cystitis. And if you want a longer course, the half-life is less than 24 hours, but you give a mega dose, so we usually repeat every other day or every third day for the duration of treatment that you want. Barrier used to be cost, but it's coming down. And I created here a fosfomycin susceptibility table from multiple studies to show that E. coli, and whether ESBL or not, and Enterococcus faecalis rates are high, other gram-positives also high, but much less reliable for other gram-negatives. So I would say if you don't know it's an E. coli or Enterococcus or gram-positive, it's probably a second line. Otherwise, it's a first line. What about fluoroquinolones? They're excellent as far as tissue penetration, treat all UTI syndromes. And we prefer Cipro for gram-negatives because why use levofloxacin that's broader? Let's keep it for respiratory infections. It has bioavailability. It has a lot of benefits. It's the shortest courses work. But They have a lot of black box warnings, as you know, the tendon, the QT, arrhythmia, neuropathy, and we don't want C. diff or MRSA, and we really want to reserve it for syndromes that need it. So we'd like to, and then you get resistance quickly. So what about oral beta-lactams for cystitis? I would say that duration is typically longer, higher return visit, lower clearance rates of uropathogens. If you're going to use it, try to use cephalexin or amoxicillin or amoxiclav, better uro availability if the organism is susceptible. And this table here actually shows that despite the reputation of fluoroquinolones, for example, beta-lactams are a major, major trigger of C. diff. There are new novel oral antibiotics for uncomplicated UTI that can be used for highly resistant organisms. They include gepotidacin, which is a new class of antibiotics. I included the information here. Pevmicilinum is an older antibiotic related to penicillin that preserves some susceptibilities and used in Europe and Canada, but not yet in the US, but it's now approved. And sulopenem is an oral carbapenem similar to ertapenem in coverage that can be used for uncomplicated UTI only. Remember that all of these are last resort. They're very costly, and if you have other options, use it. What about cystitis in men? Used to be longer courses, but now we call cystitis in men still simple cystitis, and there's a recent VA trial that looked at Bactrim or trimethoprim sulfa and Cipro and showed that 7 days was equivalent to 14 days. The only one caveat to that is a French study that showed that in febrile UTI in men, the response rates to 14 days is greater than for 7 days. It's in disagreement with other febrile UTI studies, and it's probably related to the fact that some of these patients had prostatitis. So prostatitis is a syndrome we don't yet know if 7 days is enough for. So prostatitis, I think of acute prostatitis as acute pyelonephritis except the prostate. It's an acute illness. You have fever, you have chills, you have pain at the area of the prostate or rectal. And chronic prostatitis can be infectious or not infectious and is more indolent, or just showing as seeding of the prostate but presents as relapsing cystitis with the same organism over and over and over again. If we suspect prostatitis, we use a drug that gets well into prostate, so not nitrofurantoin, for example, but trimethoprim sulfa or fluoroquinolones or maybe doxycycline, and not so much beta-lactams. And acute, you treat for 2 weeks. Chronic, you treat for 6 weeks or longer. So this is just a slide to get you back to complicated UTIs. So I'm going to talk about complicated UTIs now. And now I'm talking on the complicated UTIs by the new guidelines. So the IDSA guidelines, I was part of the committee in full disclosure, has kind of expanded simple cystitis and included in complicated UTI everything that's not that. So how do we choose for such diverse syndromes? People can have urosepsis, or they can have just a little fever. How do we choose what antibiotics to use? So we suggested a 4-step approach. First, assess severity of illness. If someone is septic, it's a different approach than if they're not. Septic by SOFA criteria, not necessarily bacteremia. Consider risk factors for MDR. I showed them to you before. Evaluate patient-specific consideration, tendinopathy, QT, etc. And for sepsis, it's very important that you know your hospital organisms because they're different from hospital to hospital. For us, cefepime preserves a lot of susceptibility, so we consider that a lot. And then if you have a complicated UTI with sepsis, usually the drug of choice is a third or fourth generation cephalosporin or carbapenem, piptazo, or fluoroquinolone. But if there is ESBL or AMP-C and the patient is very sick, I would urge you to use a carbapenem or piptazo if you know their organism is piptazo susceptible. Without sepsis, you can use a slightly narrower regimen, never nitrofurantoin or fosfomycin as for non-simple cystitis. And I would avoid as first-line aminoglycosides unless you have no choice, or the newer, very expensive antibiotics. How long? Most patients with complicated UTI, including urosepsis, including pyelonephritis, can get 7 days, and that's new. No 14 days. There are exceptions. Pregnancy, people who are not improving quickly. So what do you need? People need to improve quickly, usually by day 3 to 5, in order to get 7 days. And studies show that fluoroquinolones in 5 to 7 days are enough, or 7 days of non-fluoroquinolones, with the caveat that most of the studies are E. coli, etc., and they most looked at fluoroquinolones. But there are other studies that I will show you here, and these are studies of bacteremia, not all of UTI, some of all gram-negative rod bacteremias in the hospital. I included a bunch of them, and they were included in a meta-analysis, and all of them showed 7 days was non-inferior to 14 days in the individual studies as well as in the meta-analysis. The largest of these was the BALANCE study, very recently published in the New England Journal of Medicine, that showed that outcomes were pretty much similar to in 7 and 14 days for bacteremic patients. When do we transition to oral antibiotic, and who's appropriate for 7 days? These are people who are clinically improving, can take oral, you can transition to oral, otherwise you could finish it with 7 days. And they need to have the right antibiotic for the syndrome, and they need to be improving. And this is kind of the algorithm that's in our guidelines. And some indications for longer therapy, obstruction, abscess, low response, prostatitis, etc. But most patients with urosepsis can be given 7 days and can complete the treatment with an oral agent if it's an oral agent for complicated UTI, not for simple. And I included here 2 references from the guidelines, not going to go through them, of the doses that are appropriate for complicated UTI, different than uncomplicated for the variety of agents, and of the doses for IV antibiotics as well. And now I'm going to talk about asymptomatic bacteriuria. Asymptomatic bacteriuria is probably one of the single most common causes of inappropriate use of antibiotics, thus always has a board question on it. This is taken, this diagram just shows that people can be colonized with bacteria, and they can go in and out of the bladder, not in large amounts, and infection happens when they actually infect the bladder wall. Otherwise, you can find bacteria, but it's asymptomatic. So what's asymptomatic bacteriuria? It's significant bacteriuria, greater than 100,000 in most cases, lower for catheterized patients, in a patient that doesn't have symptoms of UTI. So who do we need to test and treat? Pregnant people and people who will have urologic procedures that can introduce that bug into the tissue. Prostate surgery, cystoscopy with biopsy, removal of stones, etc. It's not needed for joint arthroplasty if you have a prosthetic joint or if you have a valve, not indicated, overused. What about catheter-associated UTI? If once you have a catheter, it's the bladder is no longer sterile, and you have an irritant in the bladder. So you're going to see white cells, you're going to see bacteria. You ignore them unless you suspect UTI. Lower tract symptoms you're not going to have. You can't have frequency and urgency if there's a catheter in there, and dysuria may be related to the catheter. So the diagnosis is challenging. So what you want to do is you're going to use more advanced symptoms like fever or bladder pain, and that's who you treat. And the majority of people with bacteriuria and pyuria, unless you're concerned about UTI, you don't treat. And especially fungus, yeast, the by far the most common cause is colonization, often between the catheter and the bladder wall. So if you change the catheter, is still that. The exception is rarely you do get Candida UTI, or you get funguria when you have fungemia or cryptococcosis with yeast. So what do? You are gonna you're going to not treat unless they're symptomatic, and then if they're symptomatic, you might want to replace the catheter once you give therapy. And for Foley, some guidelines support exchange. For stents, there is no, or PCN, no great evidence, so it depends on how long it's been there, etc. Now a recurrent UTI case to close. So this is a 60-year-old woman who has a history of recurrent symptomatic febrile cystitis, and the frequency of infections is increasing, and she drinks a lot of water, and she gets antibiotics all the time, and she takes cranberries. And is there anything else you would do? And the question is, what's the most most supported by data intervention? And we're going to talk about that. So the two interventions that have the most data to support them, believe it or not, is liberal water drinking. You flush the bladder out. It's just like bladder washes, and it works well in RCTs to reduce recurrence of UTI. And for women postmenopausal, the single most effective intervention is estrogen topically. There's several very good studies. There's a meta-analysis, and the systemic levels are very, very, very low. So most of our oncologists will let us use it even in patients with breast cancer or others, but I would run it always by oncology. So we feel postmenopausal women with atrophic vaginitis cystitis benefit greatly from estrogen, and we encourage it. The other intervention that's data-based is methenamine salts. So methenamine salts, Hyprex, is the most common one. It turns into ammonia and formaldehyde in the urine. It's like an antiseptic. It's like an antiseptic wipe of the bladder, even though you take it by pill. And it's very helpful, especially if you have residual urine or urinary retention. And we use it as 1 gram twice daily with meals, so it doesn't irritate the stomachs. And there is a study that compared it to trimethoprim sulfa in the UK for prevention of UTI, and it was non-inferior. And there's some small studies of probiotics, especially lactobacillus, that have some effect, but the evidence is less strong. Cranberry products and D-mannose have some success in patients, but they're not very well evidence-based. And remember, the mechanism is molecules in here attached to the E. coli receptor and prevent E. coli from attaching to that receptor and entering cells. So it's only preventing E. coli. And in some patients, you just get Klebs next. And in some patients, it doesn't work. So this would be my last resort. So my approach in this woman would be estrogen first, liberal water intake, and then next step would be methenamine. So what if you want to use antibiotics? Try not to, really try not to. But if you do, the best approach is pill and pocket. They have the antibiotics at home, they drop off a urine or don't, depending on how much you can predict what would work, and they self-diagnose and self-treat. Not good for people who would over-treat. For those who have it related to intercourse, just take a small dose after intercourse, drink a lot of water, void the bladder after intercourse. If you're going to have to give antibiotics, I would say we'll do it for 3 months or 6 months, not forever, and just give a small dose. I gave some suggestions here from a very good paper that I referenced below at bedtime, and after 3 months or 6 months, stop, maybe try methenamine or other. So our takeaways for today: negative urinalysis, excellent negative predictive value for clinically significant UTI. Just today, I saw a patient with a lot of bacteriuria, 0 white cells. And the intervention I did was, listen, this is not cystitis. It's just colonization. Community and hospital drug resistance is on the rise. Know the risk factors. And for susceptible simple UTI, even though you see the word ESBL, you can use nitrofurantoin, trimethoprim sulfa, fosfomycin, and there are novel antibiotics oral that you can use for the real resistant cases. Most complicated UTIs, with some exceptions, so it's conditional, can be treated with 7-day courses as long as they improve and you feel like you have source control. And if they can take oral, it can be oral. An indication to treat asymptomatic bacteriuria is super narrow. And for recurrent UTI, prioritize antibiotic stewardship, estrogen, water, methenamine. I included a lot of references here, and I have a few questions to go over with you. And these are questions that I've seen on board exams. So this is a 32-year-old woman who is not pregnant, guidelines, and she has 3 days of dysuria, frequency, urgency without vaginal discharge, fever or flank pain. She has no allergies, no recent hospitalization, no recent antibiotic use, similar to the patient I started with, which is the most appropriate empiric first line. And you have the option of Cipro, amoxiclav, cephalexin, nitrofurantoin, or get a urine culture and then treat her. And what I would do is nitrofurantoin. So nitrofurantoin, trimethoprim sulfa, and fosfomycin are first line for simple cystitis. Fluoroquinolones and beta-lactams are reserved for next. If she was pregnant, it would be cephalexin. For the most common organism, the highest likelihood of susceptibility is to nitrofurantoin, so that's your best guess. So in a young woman, I would just give nitrofurantoin for treatment for 5 days per guidelines. 60-year-old man, he's in the ICU. He has an upper GI bleed, not an infection, and it complicated warfarin therapy, and he's now stabilized and under control and hemodynamically stable. And he has a catheter, and the nurse noted that the urine was cloudy, so she sent the urine, and it was greater than 100,000 Enterococcus faecalis. Susceptibilities are pending. The patient is in the ICU. He has no fever, no flank tenderness, and upon questioning says no dysuria. What's the most appropriate next step? IV vancomycin, Mersense is pending, oral levoflox, oral amoxicillin, remove the catheter, and then repeat the culture, or do not treat and assess need for the catheter. And the answer is do not treat and reassess. If the patient is symptomatic, you might want to remove the catheter and repeat the culture. But this is patient has catheter-associated asymptomatic bacteriuria. He has no symptoms of UTI, and it doesn't matter if he's in the ICU or not. And pyuria and bacteriuria are common, and we're not going to treat it if he's asymptomatic. It's very different if he was symptomatic. But this patient is asymptomatic bacteriuria, even if he's in the ICU, as long as he's not in the ICU for sepsis. Last question is 72-year-old woman presents with urinary urgency frequency confusion, tachycardia, temp of 39, neurosepsis syndrome. Urine culture is greater than 100,000 E. coli, and she indeed has sepsis. She has 1 of 4 blood cultures that grow the same organism. It's sensitive to ceftriaxone, cotrimexazole, and ciprofloxacin. She has a normal GFR above 60. White count is 12,000. She gets IV ceftriaxone. She's improved. She's ready for discharge. What do you do as far as duration of therapy, total duration with the IV? You decided to treat her with trimethoprim sulfa. 3 days, 5 days, 7 days, 10 days, and 14 days. And I covered it. It's 7 days. This patient has bacteremic complicated UTI. And 7 rather than 10 to 14 days of therapy are adequate for complicated UTI patients who are clinically improving when an effective, adequate oral agent is available and source control is achieved. So even if she was bacteremic, she cleared her bacteremia. We don't suspect endocarditis. It's not a common organism for that. She didn't have high-grade bacteremia. And this approach is supported by all those trials that I showed you and by the new complicated UTI guidelines. So I'm all done here. And thank you for your attention.